I'm honored and delighted to be here today, and I thank the committee for inviting me to talk about the epidemic of opioid use for non-cancer chronic pain. In terms of disclosures, in terms of financial conflicts, I'm clean and sober, largely. In terms of opiates, I'm entirely clean and sober. I also serve as chair of the FDA Science Board, which recently reviewed the opioid epidemic we did that back in March. I'm here as a University of Washington professor and not as a representative of the Science Board or the FDA. The harms of opioids are so pervasive that it's hard to be a pharmacoepidemiologist and not have written about them. But I don't claim any expertise in this area. My ignorance is broad and deep, so I would apologize in advance for any misstatements. As a general internist who prescribes opiates for chronic pain, I've witnessed sea changes in the practice over the last 2 decades, some of which have been relatively evidence-free. By way of introduction, I want to call attention to the FDA Lifecycle approach to drug regulation, not only the ongoing evaluation of the safety and efficacy of drugs during their market life, but also the active pursuit and management of the emerging knowledge about risks and benefits. Due to the limited time and my limited knowledge, I'm focusing really in the post-market setting. And as an epidemiologist, I want to review what I think are the potential causes of this epidemic, and the purpose is really to highlight targets for prevention. The model I have in mind is really more like an infectious disease model. We've spread these drugs around widely. There's a dose response adverse effect, and some of them are really quite serious. So what is non-cancer chronic pain? I work in the county hospital in Seattle and have for 30 years now. I see a lot of pain in my clinic, and it's usually chronic. And the pain is caused not only by injury and illness, but also it's occasioned by mental illness, anxiety, depression, racism, poverty, homelessness, segregation, unemployment, drug and alcohol abuse, domestic violence, social injustice, and economic inequality. So there's a lot of pain out there. As a drug class, though, opiates relieve pain and produce euphoria. And as a result, they're a controlled substance that has considerable street value. But they provide appropriate medical relief only for selected forms of chronic pain. So as an epidemiologist, I want to just step back and say, well, what's the natural history of approved drugs? The pre-approval process, which we heard nicely described this morning by Josh, basically is set to determine whether drugs are safe and effective for the intended use under the conditions of labeling. But if you look at a population of new medical entities that have been approved, what happens to them? And it's not a recent paper, but it's a good illustration. 600 new chemical entities approved, and within a number of years, about 7.5% had black box warnings and 2.7% were withdrawn. So that's actually a normal process. It indicates, I think, that the FDA is working well. You can't have perfect knowledge before you bring a drug on the market unless you don't want to bring many drugs on the market in a timely fashion. So this is the tension that they work with. The opiates, though, seem to me to be kind of a post-market outlier here. There's no drug class that would survive approval having killed 165,000 people since 1999. This is just a complete outlier. And so I've thought a bit about the historical causes, and I hope you're reading about the history of opiate use. Linda Smith from Indiana University has a very nice book about addict and the law, about kind of the early years. But I'm just going to start from the mid-last century. So the laws led to undertreatment of pain, no doubt about it. And in the 1990s, and this is a nice piece by Jane Ballantyne. Jane Ballantyne is a pain expert who actually works with us in our clinic to help us manage our chronic pain patients. It was argued largely on the basis of moral grounds that opiates should be available for chronic pain. It wasn't on evidence, but on moral grounds. And the management was based on the success of opiates for acute and end-of-life pain. So you had a principle of titrate to effect, and then you had numerical ratings that became the chief metric. And so they took a model for acute and end-of-life pain and generalized that in ways that now seem to me, in retrospect, inappropriate to chronic pain. What are the contributing causes? Well, there was attention to undertreatment of pain, and clearly there was, and I don't mean to undercut patients who are suffering, and they need relief of pain. But pain became treated as the fifth vital sign with this treat to effect approach, and it wasn't the right model. There was also what I would characterize, in order to create this epidemic, it took a lot of work. Okay, this was not easy to create this epidemic. So there was an enthusiastic collusion of the pain crowd. And who was that? It was the marketing of long-acting agents by industry, promotion by marquee professors, and some of these could even be at my institution, and endorsement by pain societies. And all this in the absence of evidence about the effectiveness of long-term use. So it's interesting to look, and I hope you have, about the promotion of OxyContin between 1996 and 2001. There were 40 speaker training, all expense paid conferences for 5,000 practitioners and over 2,000 pain education programs. Physician profiling to target high-volume prescribers. I personally regard this as a violation of my privacy. To have drug companies look at what I'm prescribing and then decide whether to try to contact me with sales representatives who receive generous bonuses for increasing the sales of drugs. And there was a generous bonus system for the sales representatives. There were branded promotional items, and I've pulled some of those down from the internet. There were originally free patient starter coupons. They're not free anymore, but I got this one off the internet. You can get 75% off your first prescription of OxyContin, and actually the manufacturer will give you 80% off. Okay. Now, this was also in the context of the misrepresentation of addiction risk. And what were the consequences of this? Well, sales went from about 48 million to 1.1 billion in this time frame. In the interim, they were also charged with misbranding and had to pay a fine of about almost $650 million for the misrepresentation. What happened, and this is my perception as a clinician in a county hospital, first of all, we have an epidemic of licit drug use, fueled by direct-to-consumer advertising, which is now up to $425 billion in sales for licit drugs. So this has gone on over the last several decades. And we created a whole generation of physicians who were well-trained to turn readily to opioids. This is a culture that was created by medicine and by the pharmaceutical industry, and the accidental and unintended result was to create pill mills. My clinic became a pill mill. And how did it become a pill mill? Well, young physicians in training were touched by the concern for their patient's pain, and they had a pill that they could prescribe that was said to be low risk, and that was promoted as the standard behavior. And so we had patients coming in, we had physicians responding to them. So what would happen, I'd have a patient that would go into a walk-in clinic and they'd come back with an opioid prescription that was not indicated, in my view, in terms of risks and benefits in any way. And they'd be asking me to renew this prescription. And this was happening a lot. And so you can imagine what happened. Our clinic became flooded with healthy young men who wanted drugs. And it became a real problem. And we started to work on it in 2009, 2010, and we've kind of worked through that and tried to manage this. So we've transitioned to a whole different culture. But this was, the medical community and the pharmaceutical industry were responsible for this epidemic. And so it's really kind of like changing fashions. This is a quote from a piece by Caleb. It says, physicians are educatable. They were, and they were educated to overprescribe these drugs. And there was a whole generation who were educated. We have the new generation is actually much more sensitive to this issue, is beginning to learn how to use medication-assisted treatment. So there's a new generation coming along. Jane Ballantyne wrote a piece on opioid therapy for chronic pain in 2003. She cautioned against high-dose use, but there wasn't an appreciation for the risks of overdose and the harms of addiction and death in that paper. And now what we have are, ironically in a way, the treatment. We have a drug epidemic that created another epidemic, and now we have treatments for that epidemic. So what's the risk-benefit profile on chronic pain? Well, there's a nice review. I'm sure you know of it. No long-term studies evaluating pain, function, or quality of life. Harms, often dose-related, include abuse, addiction, hyperalgesia, overdose, fractures, pneumonia, erectile dysfunction, motor vehicle crashes, events, mortality. There's no reliable evidence about long-term effectiveness. What might be the public health prevention efforts that are available to the FDA? Well, it can encourage focus on ongoing education. Somebody mentioned this earlier. It needs to be pain management and not just opioids. I was required to take a CME to keep my opioid license moving at the University of Washington. It was completely worthless because it was solely focused on opioids. And, you know, I lack enthusiasm for marketing, prescriber profiling, coupons, off-label promotion, aggressive sales, and expense-paid conferences for controlled substances. I don't understand what the public health advantages of that might well be. I think that's created a disaster, and I think it's something that should be eliminated. So, FDA post-marketing efforts, they can help develop new evidence on a risk-benefit profile. I'd like to see randomized trials of long duration. And, you know, I recognize all the difficulties in the trials that were described earlier, but what about a trial of, do we need long-acting opioids, and why, and is there any real benefit? So as a clinician, the advantage of a long-acting drug, especially for hypertension, is that it's an asymptomatic condition, and people are more likely to remember to take a pill once a day than 3 or 4 times a day. So the long-acting versions are very, very valuable for asymptomatic conditions. Pain, it turns out, is a symptomatic condition. And so do we really even need, is there any benefit from the long-acting agents? In the clinic right now, and this is partly what Jane is telling us and the pharmacists, in my experience, is the short-acting agents are the way we're going with chronic pain. And the patients tell me that if they don't use them for a while, they actually become more effective. And so I'm letting the patients manage their own pain with short-acting agents. A comparison of short-acting agents with long-acting agents would actually be helpful clinically for the management of these conditions. The FDA has the authority. There's enough safety concerns here. The FDA has the authority to demand a trial. I think they need to continue the active post-marketing surveillance. And I really admire the way the FDA has turned to JAMA and the New England Journal and tell us about their thinking in terms of approvals of drugs and what things are going on. Caleb wrote a piece on the action plan that was described earlier, and they need to continue to communicate regularly. This is kind of a counter-marketing effort that I think is very important. Concluding observations, well, you know, there are multiple interventions reshaping the culture now, and I'm glad about that. Pain management is important for patients, but we need to be clear. The origin of this iatrogenic epidemic is the pharmaceutical industry and the medical industry, and the medical community. Industry lacks a symmetric interest in efficacy and safety, and that's why we need a strong FDA. And there is some irony of drug development for the opioid adverse effects, though I think that's important. And the post-market opportunities, you know, the FDA does not control medical practice. And I think there are things they can do. I think many of them were discussed. I think the committee's been asked to rethink a framework. But the other public health opportunities that I wanted to focus on was new post-marketing evidence and efforts to eliminate marketing of controlled substances with a high risk of addiction. This probably exceeds current authorities, but the National Academy can recommend new authorities. This might be a place to do it. Thank you.